So we think there are two main reasons that the beta cell is so unique. And one is this, it has a unique sort of chromatin structure, and I'll tell you what that is. It's we talk about chromatin structure or histone code. And then the other is that it has a unique milieu of little proteins or transcription factors that aid in insulin transcription. So what I mean by chromatin structure is that we have meters of DNA in our cells, but our cells are only tiny, tiny little specks. They're micrometers in diameter. So we have to be able to fit this meters of genetic information into the nuclei of our cells. So the way that we do this is it's wrapped around these proteins, and it's a very, very tight complex. And what I mean by histone code is that certain cells, if they have a gene that's being transcribed a lot, like the beta cell transcribes insulin, there's a unique way that the insulin gene is packaged within the beta cell. It's more open. It's allowed to be transcribed. And that is one of the factors that makes it so unique. And the other is that it has its own sort of set of transcription factors or proteins that allow the beta cell to transcribe insulin. And so this is just a schematic showing you all the different proteins that we know bind to the insulin gene to help it make that messenger RNA that's going to go from the nucleus out to the cytoplasm so the beta cell can produce insulin. So how can we use information from this type of research to help patients with diabetes, which is why that I went to medical school and why so many of us do this type of research? Well, as I said before, we really need to know the unique characteristics of the normal beta cell and apply these principles to treating or thinking about disease states and this overall goal of developing new beta cells. And at the least, we can use this type of research while we're waiting for this cure, to develop better treatment for diabetes in the present. So I want to just close with some discussion about this project that Keith and I are going to work on. So one of the treatments that's used for patients, for the most part with type 1 diabetes, is islet transplantation. And so basically what happens is when someone decides they want to donate an organ, at the time that the organ donation happens, you can isolate the islets from the pancreas. And it's this procedure that happens in a lab. And the islets are cleaned up, and then those islets can be put back into a person with diabetes, and they're infused into now the portal vein, and they lodge into the liver. And so we hope that in that environment they're able to recover from this kind of traumatic thing that's happened to them, and be able to secrete insulin and help this patient who has diabetes. There's really been a limited success with this type of protocol because there's just lots of reasons that the beta cell doesn't do so well in that environment. Number one is it's not the pancreas, so we're actually asking it to live somewhere that it's not really intended to live. But there's also the person who gets the islets, their immune response is important, and it may destroy those beta cells. The islets have been through a lot. They've been yanked out of the pancreas. They've been swished around in a test tube, and then they've been squirted into someone's liver. So a lot of them are just going to die. I mean, it's a pretty traumatic thing for them. And then the other thing is that when we isolate them, we strip away their blood vessels. And then we expect them to go into the liver and grow new blood vessels so that the blood vessels can carry nutrients to them and help them live. And so this idea of how do we help them grow blood vessels is very important, and the one that we're going to try to do research to answer. So the idea that we have is that we want to combine different types of stem cells that we know and have seen already that these can combine to form blood vessels, combine them with the islets, and see if we can improve our methods of islet transplantation and improve outcomes. And we're going to be doing this with more traditional ways of looking at it in the lab. For sort of purposes of ease, when we do this in mice, we put them under the kidney. So we put the islets into the kidney, and that's a pretty good surrogate for what happens clinically. It's a little harder to get them into the liver in mice. It's a little easier to do it in the kidney. And that's the way we do it. But one kind of very, very progressive idea that we have, and we have listened to some people who've done this type of procedure and developed it very recently. One idea that we have is to put islets and these stem cells into the the anterior chamber of the eye of mice. And so this obviously is not going to be, we're not going to be doing this in people anytime soon. But the reason that this offers a really unique way to look at this problem is that the animal can be living, and we can do lots of, we can do tests of the islet function in the living animal. We can look at the islets and the vascular blood vessels with very sophisticated microscopes, and we can see over time the recruitment of blood vessels into the islet and the contribution that our stem cells are making. So it offers a really nice tool. It's like a little window into the body by using the eye to do this. And hopefully this video will work. Let's see. Okay. Let me just see if you can get this to. So this is what we call 3D reconstruction of the blood vessels. So these investigators put these islets into the eye of these mice, and now the green these are the islets. So by using tools like this, we can visualize the blood vessels in our islet transplants, and we can do this while the mouse is still living, and we can look at day 3 after transplant or day 7 after transplant, and we can get an idea of what's happening with time if we use different combinations of stem cells. I'd be happy to answer any questions.
I have a question.
Okay.
2 weeks ago, I read where Colorado, where I'm from, has the lowest incident of.
Yes, it does.
And I noticed on your slides they have the lowest incident of diabetes.
Yes.
They said it's a healthy state.
It
is. I'm being one of the fat ones. Is there any incidence because of the altitude of the?
I don't think when people talk about Colorado, and it is certainly held out as one of the healthiest states, and the reason I've always heard people say that is because you guys are active in Colorado, so you have beautiful mountains to climb and places to hike, and so right. But I do believe that's one of the reasons. I had not heard the idea of altitude, but that's an interesting hypothesis.
I realize we have many things to do there, but it's just interesting that when on your slides.
Colorado is definitely one of the states that, but I should say, as a qualifier to those maps, even the healthy states, the ones like Colorado, our definition of healthy is becoming kind of skewed because of these statistics. So even Colorado is starting to catch up, which is kind of alarming for us as physicians, what we're going to do to help patients. Any other questions?
I'll just restate that question I asked. What is the difference between diabetes because you cannot properly use insulin or the deficiency of insulin? Now you're talking about being a deficiency of insulin with your beta cells.
Well, actually, both types of diabetes are. I'm kind of beta cell centric, as you might have guessed, but so type 1 diabetes is definitely the very first thing you see is the immune system destroys the beta cells. That's not the more common type of diabetes. That's only 5 or 10% of the cases. But in type 2 diabetes, yes, there is insulin resistance. So your beta cell will be able to kind of keep up with that for a while. So it does its best to grow, and new beta cells form to try to secrete more insulin to overcome the insulin resistance. But at a point, for lack of a better term, in endocrinology, this is our technical term for it, it poops out. So it has just done its level best, and it says, wait, you're asking way too much out of me, and it says I'm going to stop. And there's evidence that in type 2 diabetes, despite giving you lots of really nice medications, that your beta cells die. They undergo apoptosis, and you no longer have beta cells to secrete insulin. So understanding what happens, what's that switch from being able to keep up to dying is important. Other questions? Thank you very much.